Good morning, everyone, and thank you for joining our briefing on the urgent care industry. Today, we'll share some overall background information with you, but focus particularly on our role in helping fight COVID-19. My name is Llewellyn Horwitz, and I serve as the Chief Executive Officer of the Urgent Care Association. UCA represents professionals and organizations providing urgent care across the country and abroad, and we engage with many stakeholders around and surrounding the healthcare arena, including local, state, and federal agencies. Urgent care centers are located in every state and nearly every congressional district. UCA sees its role as one of defining the industry, making connections, and fostering excellence, and we do that through a variety of programs and partnerships. The Urgent Care Association's family includes the College of Urgent Care Medicine, which focuses on the practice of urgent care, the Urgent Care Foundation, which is our research fundraising arm, the UCA PAC, and our industry publication, the Journal of Urgent Care Medicine. We also work closely with partners to our industry, and today we're pleased to acknowledge the support of some of those partners for this event, who are Cepheid, BD, and Quidel. So let's talk a little bit about urgent care centers and what they have grown into over the past 20 years. Traditionally, our centers see patients of all ages on a walk-in basis for a wide range of illnesses and injuries, usually 7 days a week and 12 hours a day. There are over 10,000 centers in the US, and when COVID-19 arrived, the first case was discovered in an urgent care center in Washington State, my home state. Since that time, we've done millions of COVID tests, and I'm honored to be joined today by the leaders of some of those urgent care centers who not only rose to this challenge, but exceeded all expectations, and they're going to share their stories. While they're talking, I want you to also remember that the majority of urgent care centers are small businesses. So in addition to all the well-known challenges across the healthcare community with regard to PPE shortages and lack of access to testing and vaccines, our members also face small business owner challenges. More than half of urgent care centers, based on the size of their business, could qualify for and likely have benefited from Paycheck Protection programs. We've heard from them, and we hope that you have too. We're very appreciative of that assistance to be able to keep these critical centers open and hope that program will continue so that we can continue serving your communities. If you look closer at the reach of urgent care into communities, you'll find that historically, before 2020, we've served approximately 160 million patients per year. We're spread across the country, and more than 3/4 of Americans live within a 10-minute drive of urgent care. We've also opened extended hours and on weekends, so we're all about access, and you'll see how important that was in our ability to engage almost immediately in fighting COVID. In addition to being in every state, we are in all types of communities serving all demographics, including underserved areas and groups. We have many patients over 65. We're located in rural and urban communities, and we provide essential care for communities of color in all of these areas. Our open door access and our natural ability to quickly respond to the needs of our communities was never more valuable to our country than in urgent care's response to COVID-19. Within 2 weeks of the first case, many of our centers had added telemedicine to further improve access to care and began testing as soon as they were able to get supplies. As you can see from this slide, through the summer and fall, for over half of urgent care centers, COVID testing made up 50% of their visits. Because we were able to respond so quickly and so consistently across the country, we found ourselves filling in for primary care providers and sometimes even specialists who had not stayed open. We were able to continue to keep patients out of the ER, which had not just become a matter of cost and convenience, but of life or death. Our members coordinated closely with departments of health and other local leaders, particularly in New York, to try to manage all the challenges we had in securing testing information, supplies, personal protective equipment, and tracing programs so that we could help keep other essential workers in the field. We all know that the pandemic has spotlighted gaps in our medical response networks and healthcare inequities in some of our most vulnerable populations. But I hope that in the stories you hear today and have read about in the Voices of Urgent Care information that we sent you, you'll also see how important urgent care was in mitigating a crisis that could have been much worse had we taken a less aggressive stance, despite the challenges we faced and in some places continue to face in doing so. I'd like to move us now to some of those frontline individuals by introducing Dr. J.D. Zipkin, Chief Medical Officer at Go Health Urgent Care. Dr. Zipkin directly oversees the New York City-based urgent care centers. Please join me in welcoming Dr. Zipkin.
Hi there, thank you for having me. Next slide, please. Again, I'm Dr. J.D. Zipkin, Chief Medical Officer at Go Health Urgent Care. Next slide. Go Health partners with world-class integrated and innovative health delivery systems across the country. You can see our 160 urgent care centers across the map including 52 in the New York City metro area that serve a diverse patient population. We've stayed open and have been taking care of COVID patients since the beginning of the pandemic. And our role is really to protect and offload our emergency rooms and our hospitals and really reduce the risk of transmission of COVID in the community. Next slide, please. The reason that we were able to have such an early response was from coordination with those health systems partners that I mentioned a moment ago. We were able to access PPE stockpiles from those partners and redistribute them to frontline. So as elective surgeries were no longer happening, we were able to take those supplies and redeploy them as needed. We had access to infectious disease experts that supplemented CDC and Department of Health knowledge, and we had access to central command in those health system partners. It allowed for integrated outpatient referrals as needed, as well as streamlined inpatient admissions when we did find a COVID patient who did require a higher level of care and we weren't able to keep them home. Next slide, please. The industry as a whole in urgent care is elastic, and that's by design. We're experts at being able to scale quickly, especially in the wintertime, our busy season, and throttle back in the summer when the community needs are not as high. Urgent care typically has a significant group of per diem employees and medical providers who can provide additional shifts and coverage as needed. And just as we are able to redeploy our PPE and our supplies to front lines from other areas of the healthcare system, so too were we able to redeploy our personnel even across different markets. So as certain physicians were furloughed in one area of the healthcare system, we were able to pick them up and utilize them on the front lines of healthcare, even in the urgent care space. And again, as I mentioned, because we are such an integrated a network of urgent cares here at Go Health, we were able to utilize medical providers across states and between our markets who were able to get disaster privileging and credentialing across those areas. Next slide, please. We exhibit a lot of adaptability in the urgent care space. We were able to really meet patients where they needed to be met, and sometimes going into curbside testing opportunities or even carside, as you can see here in this picture. We had omni-channel access to healthcare. And what that meant is that a patient could start in the virtual space on telehealth, really reduce the amount of time they spent physically in healthcare, right? There was a concern earlier in the pandemic of how much time patients were spending physically in the healthcare space, whether that was in the emergency rooms or even in urgent care. So we can minimize that time by starting them on telehealth, asking and answering questions there, and then bringing them into the physical brick and mortar sites really on a minimalistic basis to get those tests done, get those swabs done, and getting them back out, get them home, and get them to safety as much as possible, all while maximizing the safety profiles of our centers, again, to minimize that risk of transmissions. We were able to travel to remote areas, to rural areas, and really to improve access to care to all areas of the country. Next slide, please. And sometimes that meant being outside in not so great weather and adapting and thinking through ways that, again, we can meet the needs of our communities. Next slide. When it came to testing, we at Go Health Urgent Care were the first in the country to have access to mass lab-based testing, thanks to our amazing partnership with Northwell Health and Northwell Labs. Here in the picture, you see on the right, the amazing head of Northwell Labs, Dr. Dwayne Brining, standing next to Senator Chuck Schumer. I think he snuck in for a photobomb there as our union rep. And when I say that we were the first urgent care, that really extends beyond just urgent care. We were one of the first outpatient settings anywhere in the country to have access, since Northwell Labs was able to research and develop their own COVID tests, parallel to the CDC and Department of Health offerings at the time. Fast forward 1 month later, you can see the dates there. In early April, we were able to partner with Abbott to launch really the first urgent care, and again, probably the first outpatient option for rapid testing at scale. And that's not the antigen test, that's very common. that has variable accuracy. That was the high accuracy molecular testing. And we had the honor and privilege to be able to offer that to our patient population as another first in the country, and really, again, at scale, identify the patients who had COVID and reduce the risk of transmission in their community accordingly, or get them the resources that they needed. Next slide, please. And part of that came down to treatment as well. So we were able to see that monoclonal antibodies received emergency use authorization. Those are things that we may have heard of in the news, like Regeneron or bamlanivimab and other monoclonal antibody offerings. When GoHealth Urgent Care identified patients that were positive for COVID-19, and specifically the at-risk, high-risk patients who were more likely to go on to hospitalizations or be at risk of even dying from COVID, we were able to, again, partner with our health systems to get them in to ensure that they were able to have access to those therapeutics, access to that treatment to reduce the risk of hospitalizations and reduce the risk of death. Next slide, please. We were among the first urgent cares in the country approved to administer the COVID-19 vaccine. I'm happy to report that we started that at the end of 2020 and have really been able to use this as an opportunity to both vaccinate our own employees, vaccinate other healthcare, frontline healthcare providers, and right now in California start to, as the phased rollout continues, vaccinate other members of our community who are at risk of COVID-19. Next slide, please. So there are a few opportunities for advancement here. So first and foremost, I would love to have Congress see urgent care with a top of mind awareness that we are the tip of the spear in the outpatient realm. We are the counterparts to emergency rooms and to our hospitals. So early inclusion in national efforts would go a long way, and focus on offloading those inpatient hospital burdens, as we have been in the urgent care, would just be amazing. As I mentioned, our early response at GoHealth really came from a coordinated effort with our health system partners. And being able to roll that out at the national scale would be a tremendous way to improve response times and overall coordination across healthcare systems, both for this event, this pandemic, as well as anything that may crop up in the future. Because when we have a single registration process for things like the COVID vaccine, when we have a single reporting structure for COVID cases, and again, reporting who we are vaccinated, it truly does speed up response. Right now in the country, we have 50 states doing more than 50 different ways of these tasks and these processes. So from the many, it would be great if we had one standard. We know standardization across healthcare saves lives and improves efficiency. It would be great if we had one standard, one requirement for our electronic medical records, one standard for our administrative processes and requirements to truly advance our rollout and advance our response times. Next slide, please. I do want to summarize, and I want to end on a high note. So GoHealth Urgent Care has provided unparalleled COVID-19 support throughout the pandemic. I hope I have shown that we have been a leading role from the beginning of the crisis. We've been able to adapt at scale, rapidly change based on regulatory and medical guidance. We provide flexibility like no other, and we provide priority access with the most advanced testing capabilities, operational expertise, and we can deploy these things rapidly. We have tight integration with the most advanced and innovative health systems partners to serve our communities, as well as employers and employees across the country. And that really comes down to multiple nationally recognized care innovations. Next slide, please. So to give a sense of where we're going, as we slowly start to reopen our nation, reopen the economy, we at GoHealth are the healthcare, the COVID-19 testing partner of choice. We are in San Francisco International Airport, helping reopen travel. We are working with employers across the country to get people safely back to work, safely back to travel. Next slide, please. And recently we partnered with Madison Square Garden to be able to reopen other parts of our economy and entertainment. Madison Square Garden just opened up at 10% capacity with socially distanced seating. And we are the partner of choice for testing to ensure that people coming into Madison Square Garden again, as we are able to reopen, are doing so with negative COVID testing. If you go to the next slide. Looking forward, we continue to partner with employers and other opportunities across the country to ensure that we can reopen this country safely. Thank you so much.
Thank you, Dr. Zipkin. Now I'd like to introduce you to Roger Hicks. Dr. Hicks is the medical director and owner of Ubidox Urgent Care in Grass Valley, California. As a small business owner and practicing physician, Dr. Hicks has a unique perspective, and his experience just during the pandemic reflects some of the challenges faced by urgent care centers located in rural areas. Please join me in welcoming Dr. Hicks.
Thanks, Llewellyn. I sort of represent the opposite end of the spectrum from JD. I have a single clinic, which is located in Grass Valley. Grass Valley's in Northern California, between Sacramento and Lake Tahoe, just north of Interstate 80 in the foothills of the Sierra Nevada. It's in Nevada County, which has a total population of just over 100,000. And the county is divided by the Sierra Nevada mountains. So about 25,000 people are in the eastern county and 75,000 on the western slope where Grass Valley is located. We have three small cities, which you can see on the map there: Grass Valley and Nevada City on the western side, and Truckee on the eastern side. We have the highest percentage of senior citizens in the state. The California average is 15% seniors, and our county has 30%. Next slide. Grass Valley and Nevada City were founded during the gold rush, and people live here because of the outdoors and small town rural lifestyle. Many people come to escape San Francisco Bay Area, big cities, or Los Angeles or some other big city. Next slide. Others, like me, are drawn here by the Yuba River or by the close proximity to skiing at Lake Tahoe, which you can see in the background there. Next slide. I used to work in big city emergency departments, and I realized that people who came to the emergency department for cuts or broken wrists often waited for hours while I took care of car crashes and heart attacks and people with strokes. Studies have shown that between 60 to 80% of ER visits could be handled in an urgent care setting, and that's what I experienced. Like urgent care centers everywhere, ours provides an alternative to the emergency department for people with minor injuries and acute illnesses that aren't life-threatening. We take a load off of our local emergency department by seeing people that need care that day, but don't need an ER. And we save the healthcare system money. The average urgent care visit is about 1/10 the cost of the average emergency department visit, $150 versus $1,500. Next slide. There are differences, obviously, between our clinic and urban settings that JD told you about. In the big city, it can sometimes seem like there's an urgent care on every other corner, but we're it for our community of about 75,000 people. We have 2 hospitals in the county, one on the eastern side in Truckee and one on the western side in Grass Valley. And we're the only urgent care in the western county and have become part of the medical landscape since we opened 20 years ago. People rely on us to be here for them, whether it's because they can't get in to see their doctor or they don't have any chronic illnesses or medical problems, so they never saw the need to have a doctor. Maybe they're visiting from out of town, or they just can't find a doctor because, like the rest of rural America, there's a shortage of physicians in our community. There are unique challenges in rural communities. Like many other urgent cares, as JD mentioned, we began doing telemedicine at the beginning of the pandemic. And we found that about a third of our visits didn't work because of poor internet connection, inadequate cell signals. So just a little side plug here, access to broadband is not only a equity issue, it's a healthcare issue in rural communities. Other challenges are there's geographic adjustments for reimbursement from CMS and other insurers. It's lower in rural areas, and that makes it more difficult to attract and retrain staff, from medical assistants to nurses to x-ray techs to doctors. And like most urgent care centers across the country, the majority of them are small operations, as is ours. I wear many hats and they don't all fit. We don't have a department for every problem. And if one of our staff gets COVID, we can't easily replace that person. Next slide. Oops, sorry, no, go back one, please. So we've been a key part of our community response to COVID since the beginning of the pandemic. Every Friday morning since March, I'm on a call with county public health officials, officials from the 2 hospitals, and local physicians. I've also been asked to be on regular calls with business leaders and elected officials from the county in our 3 cities. And at the county's behest, I've made a couple of PSAs and write regular columns in the local paper about COVID, from masking to social distancing, testing, and vaccines. We've been doing, we do both kinds of testing for COVID. We've been doing PCR testing since March. That's, as JD mentioned, that's a more accurate type of testing sent to a reference lab, can be used on people with symptoms or without symptoms. And we also do rapid tests or point of care tests. We do the antigen test. It's not as sensitive, and it's intended for people with symptoms of COVID, or is also used in settings where there's a serial testing, like testing every week or twice a week, like skilled nursing facilities. We use this to test our staff. We've tested thousands of people, mostly in their cars, the vast majority. But we also test people inside the clinic and exam rooms when they come in for other problems and our clinicians feel there's a possibility of COVID, or we see people with known COVID, sometimes because we make the diagnosis right then, and sometimes because they feel they're not doing well. We work closely with our local hospital when we diagnose COVID, and in the appropriate circumstance, we refer them to the hospital infusion center for monoclonal antibody treatment. As you can see from the bar graphs, our demand for testing reflected what was going on in the county. There was a spike in July, it went down a bit, and then another spike in the fall, particularly November. And then that's the graph with the blue bars. And then our positive COVID tests, these are point of care tests, but there was, again, a spike in July, and then another one that started in November and just went crazy in December and January and is coming down now. We tested thousands of people, and I think that's what I want to say about that. So next slide. We've also been involved in in vaccines. We feel like we have an obligation to the community to vaccinate because we're here and people know about us. Early on, a couple months ago, our public health department appealed to local providers to help with vaccinating because there was no national plan, and this public health department's generally, this one included, they just don't have the resources to vaccinate everyone in the county. So they asked us for help. We started with vaccinating first responders and in-home health service workers, and now have expanded out to people over 65. But there's problems. We get paid $16 and change for giving a vaccine, and that includes phone calls to and from patients to schedule them, doing all their HIPAA documents and consents, going over the CDC pre-vaccine checklist with them, administering the vaccine, observing them for 15 to 30 minutes afterwards for possible reaction, and then scheduling for their second vaccine. We're not allowed to charge for a nurse visit for this, just the $16 for the administration fee, even though going over that medical checklist and watching them after the vaccine is administered for a reaction, that's definitely a nursing function. So we lose money on every shot we give, but we do it as a community service. There's administrative challenges too, as JD mentioned. We really need a software for scheduling, both a public facing software that people can just go on and sign up, and one that is used by vaccine administrators. And even though California is the home of Silicon Valley, there isn't one software at the moment that everyone can use. It's still being tested. It's like we're building the plane while we're flying it. There are also lots of reporting requirements. We have to report who was vaccinated to the California Immunization Registry, and inventory must be reported daily to the county and the CDC. That kind of software there should be part of the scheduling software, but there's a variety of reporting mechanisms and softwares out there for both of those things, and there's no standardization, which just makes it more confusing. It changes constantly, and a new software is being tested right now for public facing, for scheduling, and for vaccine administrators for scheduling and reporting. So that's frustrating. Everybody knew the vaccine was coming, and we're just developing software now. There's economic challenges as well. We lost money last year because on testing, one of the major insurers is paying us $9 for the rapid test, the antigen test that we do on site. The test kit alone costs us $23, and they're paying us $9. And that doesn't account for the PPE, the personal protective equipment that we have to use, and the staff time. Since we're a small operation, we don't have the leverage to negotiate effectively with the big insurance company. And during the pandemic, we've been bombarded, like other urgent care centers across the country, with phone calls about, can I get tested? Can I get vaccinated? So we've had to hire more staff to field phone calls, to do the swabbing and to the vaccines. We definitely have had supply chain challenges because, like most urgent cares, we don't have that connection with large healthcare systems that GoHealth and does. So maintaining a supply chain became the main focus of one of our nurse managers for months. We've also found that the personal protective equipment is 5 times as expensive. The cost went up by a factor of 5 in just the first few months of the pandemic. This is not sustainable. We don't have the deep pockets of huge healthcare systems like most urgent cares across the country. We need to be paid fairly for the services we're providing. We responded quickly like other urgent cares and met the need. We met the call from our community. We're not trying to cash in on the pandemic, but if we're going to continue to be here to serve our communities, we need at least to be able to cover our costs. I think I'm typical of the average urgent care operator in this experience. And so my ask is that you please address these issues. Compensation for testing from insurers and CMS, and the compensation for vaccination needs to be fair. Thanks very much.
Thank you, Dr. Hicks. Now I'd like to introduce you to Andrea Malik-Rowe and Lisa Mickelson. As president and co-founder of CRH, Andrea brings significant corporate finance experience to advise the clinic and regional levels on capital-efficient operations. As a very hands-on operator, she's involved with nearly every area of the company. Prior to CRH, Andrea was a director at Arcapita, a Bahrain-based private equity firm with $9 billion in assets under management, where she focused on investments in the U.S. healthcare sector. Lisa Mickelson joined Well Street Urgent Care as the Chief Executive Officer in March of 2020. She's a seasoned healthcare executive with more than 15 years of multi-unit operations experience. Prior to joining Well Street, Lisa was the COO of Benevis Dentist Practice Management Services, and she was an integral part of the company's growth from 6 offices in 2005 to a network of 165 offices across 18 states by 2019, with over 2 million patient visits annually. Andrea and Lisa are doing a shared presentation on how their urgent care centers partnered with businesses in their local communities to mitigate the spread of COVID-19 in Georgia. Please join me in welcoming them both.
Thank you, Llewellyn. We appreciate the introduction. We should also note that Lisa and I have known each other for over 20 years and have shared cubicle spaces back in our 20s a long time ago. So we're also our most probably competitive people that are on this call, because Lisa and I are both the 2 largest urgent care chains in the Atlanta metro area. So we share a lot of things in the past and today. CRH, I'll just give a quick overview so we can get into the meat of it, but we have 64 locations. We're across 4 states. We are the largest urgent care in the state of Georgia. We're partnered with the Emory Healthcare Network in Georgia. We also have centers in Alabama, Florida, and Maryland. We are a family of brands. Our brands are down at the bottom so that we do those more locally in the states that we serve. We do have access. That is one of the keys that you should be hearing about urgent care, from Roger, having a small single center in the foothills, to JD having them with large MSAs. It's the same with Lisa and I. We have small communities that we serve, as well as a large metro area. For Atlanta in particular, we can reach 90% of the Atlanta metro area within a 15-minute drive of our centers. And we do accept all insurances, including government-based pay. Lisa?
Thanks. Next slide, please. Thank you, Ellen, for the introduction. I'll talk just a minute about Well Street Urgent Care. We have 50 urgent care centers across Michigan and Georgia. Similarly to JD, we partner with health systems, so have a partnership with Piedmont and with Beaumont in Michigan. Similar to what Andrea shared, we cover urban, metro, rural in those communities, serving a diverse patient mix and also using a wide variety of payment options. One of the things I'd like to share with you today is a little bit more about the stories and the team members and the access and the role that we've played that you've heard from others during the pandemic. You see some smiling faces here. Our team members, we have incredible physicians, advanced practice providers, medical assistants, and office staff that are as diverse as the communities we serve and have really stepped up and gone above and beyond during this pandemic. If we go to the next slide. I think a theme that you've heard here today is that urgent care's us specifically, as well as across the country, filled a much needed role of patient care, particularly during the early times of the pandemic. It may seem very long ago or foreign to say, but there was, a time when, we were afraid to go inside. We were afraid to go see a doctor. Patients were and still are afraid to go to an emergency room. And we've found ways, and we've talked about this, and we'll talk about it a little bit more, to stay open and serve patients. And whether that be outside, curbside, drive-throughs, inside as well. But I just also want to share that this is more than just about testing. As you heard Roger say as well, that there's a role in testing, but we are really here to provide care when there was uncertainty and not knowing what to do and when to go to the emergency room and what steps to take. Urgent cares filled that role in providing care to ill patients during the pandemic, as well as many other patients that still had needed an X-ray or needed stitches. Go to the next slide.
And as Lisa mentioned, it was vitally important to make sure, mainly from patient perception as well, that we could provide a safe place for the patients to be seen. As you can see in some of these pictures, whether it's going out to the car with our providers, whether it's the person who, broke their ankle. Lisa and I both have young kids. They're doing virtual school. My sons are playing in the backyard, and I know any second they're going to fall and break their arm. And I'm not unlike any other mother that is having to deal with this. And where do you take your kid? You don't want to go to the emergency room. You're scared about that, and your primary care might be closed. That's what urgent care filled, was the opportunity to still be seen safely for a variety of different areas. You still needed medication refills. People still had chronic conditions that needed to be seen, and urgent care stepped up and filled the gap. I will say it wasn't easy to do that, and it required a lot of perseverance from a lot of us, including PPE. As you can see in this picture, if we had this picture a year ago, pre-pandemic, you wouldn't see the gowns and the masks and the face shields and all those different items. And it did, as Roger said, it did take more staff to go in and out of your center, and the staff were scared themselves trying to show up with and work on the front lines. Can you go to the next slide, please? So while we were in the centers, we were also trying to figure out how to serve people outside. So a lot of it turned into frontline testing pretty early, for us, but there were a lot of challenges with that. PPE is one of them. So to do this testing or even see the patients inside, as you saw on the last slide, it required gowns and masks and more gloves and lots of other items that we had some of, but didn't need for every patient all the time. And as you heard Roger say, the price of those items skyrocketed for the small people as well as for the big guys. So you'll see in a little bit some of the cost differentials that we had to deal with, let alone how to even find them. You had to be pretty scrappy to do that. We ended up having our team drive around to Sherwin-Williams stores and pick up paint suits, or go to the Home Depots and try and figure out how to get, a rain suit, to stay outside for a lot of these items. So the costs were higher. It was hard to get. And when you did get a beat on a supply, Lisa and I actually would text, hey, I got a beat on some masks. I can't use all of them. Do you want to split the order? Right. And so trying to work together, even with people who might have been your competitors in the market, but trying to work together for the betterment of the community, what was a pretty big item for us. I'll mention one of the things that we did pretty early was pivoted our business. So we opened up our first drive-through center on March 20th, which was exceptionally early. We were thinking if we could just stay open for 2 weeks with the amount of PPE that we had, we'd still be doing the community a service, and we'll go for it. And that center, thankfully to say, that center is still open and still seeing lots of patients for testing. We opened additional centers on top of that, additional drive-through centers. And we also opened up 14 pop-up centers. This is a little different than some of the others that are on this. So these are not in our brick and mortar. These are, think, a parking lot of a Walmart or at a Burlington Coat factory that isn't open anymore. We took their parking lot, or in front of a grocery store, or some of these other areas in the communities. And importantly, what that did is it added access points for underserved communities around the area for us to provide testing and other resources for them. We were lucky enough to be one of the first 8 to get the rapid antigen test, one of the first 8 healthcare systems. So while we opened March 20th with PCR, by Memorial Day, we were able to add the rapid. Our demand skyrocketed after that, because we are living in a me and a current situation environment. They wanted to know to keep their family safe. What you'll also see is the picture here on the left. It's not a great picture. It's me taking a selfie inside of a mobile mini. But this is one of our labs that we had at Emory University, because we did all of Emory University's return to school testing. So that included staff, faculty, students to bring them back onto campus, and we routinely tested them during the fall. We did over 40,000 tests for Emory University to keep their campus safe and keep them open. And you will hear stories like that across the country of urgent cares, in particular, neighbors serving neighbors, trying to make sure that we're keeping the community open and safe throughout. So I'll turn it over to Lisa. Next slide, please.
Thank you. Just wanted to share a few more pictures briefly that demonstrate just our ability to pivot and move quickly. As Llewellyn mentioned, I joined as the urgent care world on March 16th, which for many was the first day where the world significantly changed. When I joined, we didn't have any capabilities to do virtual visits or start visits virtually and then bring patients in-house as needed. So part of that OmniCare. Within 2 weeks, we were up and seeing patients virtually, and during shelter in place, and for many patients that were first really scared to go seek care anywhere, there was a significant need for that. So similar to all the stories you hear, we didn't know if and how we'd be reimbursed for that. There was certainly parity laws in one of our state and it's not in the other, but this was a need for our patients, and we've been able to work to figure most of that out, but it has certainly taken a lot of hard work and challenges, and some payers that had good intent, whose systems weren't set up to adjudicate claims and work and rework, and others that weren't as good of partners working through that. But these are just some more examples and ways that we adapted to be able to provide that patient care, and are working and facing all the extra challenges to try to get reimbursed for doing that. A couple other interesting pictures here. You'll see that big metal box. It looks like a shipping container. That was a sick pod for us for a while, where we weren't seeing sick patients inside. So we'd have sick pods, and then with special air conditioning units and increased HEPA filters and foggers that would fog them down between patients. So just, again, different ways that added to complexity and cost for us to be able to go serve patients. Next slide.
Yeah, we wanted to put a little bit of humor in here, as JD had mentioned, and Roger as well, but that nice tent you saw in Lisa's picture, we also had some too. We call them tent carcasses, but when it rains and the wind blows, they're coming down. So we have people trying to go through a drive-through center on a bicycle. We have to figure out all the weather elements. In Hotlanta, it's hot in July, and they're out in all these suits, and they're outside, and trying to keep the staff cool. And then the flip side of that is in January, February, trying to keep them warm and trying to figure out how to stay open is always interesting, let alone how to keep supplies, coming, because there was clearly a demand from the communities to have us stay open. And I'll mention the communities have been a very big partner of all of ours, whether they, drop off meals for our staff, whether we get a nice big sign, as you saw before, to say thank you. The communities really did rally around, I think, all of healthcare, but it was nice to see all the support that we did receive. Can we go to the next slide? One of the things we mentioned earlier, and we sort of touched on it, but we wanted to put some numbers in front of you, is what this extra cost really has been for us to try and serve these patients, whether it's personnel. A lot of our staff are asking, as I sort of said, as hazard pay. People want to get paid more. We need more staff and at higher prices, and there are higher training costs to do that. So there is a significant increase in personnel costs that we see. We mentioned the PPE costs. It's one thing for the existing supplies to be at a higher price, but now we need more, whether it's the tents, the shields, the foggers, the other things that you've heard us talk about, that those are expensive on a per patient basis for us to have. as well as the test kit costs. As you heard Roger mentioned, we did get higher prices, and it almost doesn't matter whether you were large or small. The vendors were mandating what the price was, to you, with no ability to negotiate that. And so we as urgent cares, and as Luella mentioned, we as small businesses across the country were sort of added these extra costs, and in a lot of situations we were not reimbursed for them, or the price that payers were willing to pay was below our costs, and yet we still stayed open. We still took the hit because it was the right thing to do. In a perfect world, we would at least get our costs back, if not a little bit more, for the time, energy, and effort that we are putting in to try and keep our communities safe. Next slide, please. One item in particular that we might ask for your help in, as you've heard the theme around vaccines and trying to get adequate pricing for that and adequate pricing for these tests and the other items, those are clearly issues that we would need to address. There's another more nuanced issue where some of the payers in a lot of states will give you a flat rate for your service, whether you were seeing someone with a broken bone, whether you're seeing someone that needs stitches, whether you're seeing someone who just has the sniffles, they pay you the same amount per visit. That's what's called a global rate. And in a lot of those cases, whenever COVID happened, and you just saw our increase in cost, a lot of those payers said, you're still going to get your same global rate. We want you to eat all of those costs. We still want you to provide COVID tests, but we're not going to pay you anymore. Or we still want you to do, whether it's a vaccine or see all of our patients in these more clean and different environments, but we're not going to pay you anymore for your increased costs. And so what we would love to have happen is what's down at the bottom of this page called a bill above, which is you could have your global rate for your office visit, and then for COVID tests in particular, or the vaccine, to get an added reimbursement for those. We have been successful doing that with some of those payers. It'd be nice if it was mandated that any global rate contract would have these extra reimbursement items for the COVID specific, pandemic specific responses, whether they be tests or the vaccines. That would be helpful for all of us, so that we can continue to do, as Roger mentioned, he's doing it but at a loss. But if we want this to survive, we need to be able to continue to do it and at least break even, so that you have all these access points open and helping all the local communities. Next slide.
Thanks, Andrea.
Yep.
So we shared a little bit and shared some of the faces and the people on our teams. I think our key message that we want to get across is that, we're here and we're in it and we're doing great work and we're here to help. Some of urgent care association members, and some of the urgent care are larger, some are smaller. But I think a common thread is that we're all very nimble and adapt, and are here and are trusted community resources where individuals go to seek care. So we just want to reiterate, communicate that. We've shared some of the stats: 10,000 urgent care centers across the country. We're open 365 days a year, mostly 12-hour days. We are in our communities working for the safety of our staff, of the individuals in the communities, for businesses, schools, daycares. And we are here and hopefully demonstrated how we stepped up and what the urgent cares provided during the pandemic. And please know we're here for whatever is next. We're filling a vital role in healthcare. We're able to provide vaccine distribution. You've heard many of the challenges, and Roger shared so well. But we are playing and can continue to play a big role in serving healthcare needs across the country.
Yeah, and to wrap up on that, as we said, we were here, we are here, we will be here, and our whole point is we really are community, local access for small communities, impoverished communities, well-to-do communities. We are everywhere, across the map here for the country. There is a lot that we've already lived through. There's a lot that will be coming that a lot of us still have to be nimble and adapt to. If you're a Game of Thrones fan, we've sort of put in here, winter is coming. We're not out of this yet. We still have another, winter coming ahead of us too. And so we just wanted you to all to know that we are all here to help you and to, make an impact on our communities. Thank you, Llewellyn.
Thanks, Lisa and Andrea. I think we have time for just a question or two. Let's talk about winter. Although it's only March, winter, the season truly is coming, which is last year was not a traditional combination flu season that we were all expecting, primarily because people were staying so isolated. But as people get back out into the community and we open back up again, have you all started thinking about how you are preparing for fall and a potential combined 2022 flu and COVID season? And what does that look like for you all as from a preparedness standpoint of regrouping again up against some of these challenges if we don't get them solved?
Yeah, it's interesting. What I'm really looking forward to is additional technology in this area, right? So we started to see really midway through this winter season, the very start of combined COVID, flu A, flu B type testing. And I think that's going to continue. For me, the pandemic itself, I see a light at the end of the tunnel. It's distant, but it's there. And I suspect even if we end the pandemic itself being widespread community transmission, we're still going to be seeing COVID-19 pop up in isolated cases here and there throughout our communities. So I think what I'm concerned about for this upcoming winter is really ensuring that we are able to differentiate COVID from flu A and flu B and provide, again, that same sense of protection and safety to the communities that we have been this year.
Can both you and Dr. Hicks then address those public health benefits around the point of care testing and how that's going to factor in to being able to address that?
The point of care testing is just so valuable because it provides, a quick answer to whether somebody has COVID or not, or flu A and flu B, as Dr. Zipkin said. This allows contact tracing. It allows people to quarantine when they need to, and not quarantine, when they don't need to. I think we all experienced last summer, at least in California, the turnaround time for a PCR test that was sent to a lab was up to 2 weeks, sometimes 18 days, which makes it completely useless because if it was positive, you only had to quarantine for 10 days anyway. So when you get the result back 18 days later, I mean, it's completely useless, and it makes any sort of public health contact tracing impossible.
Which makes these coverage issues all the more important as we face this upcoming season. One by one, real quick, if you had to pick, what are the most important legislative actions that you believe Congress should be addressing as they work through this stimulus package and any remaining legislation? I think you've done a good summary.
Well, I would say from the small operator viewpoint and maybe from everybody's viewpoint, we should be compensated fairly for vaccinating. I think we should be allowed to charge a nurse visit along with the administration fee, and we should be compensated at least our costs, and as Andrea said, a little bit more than our costs for testing, so that we can continue to be here to serve the community.
Thanks, Dr. Hicks. Andrea?
Yeah, I'll jump in. I think consistency is important, and I think JD mentioned that earlier. So whether it is consistency in how we report, We are across multiple states and multiple DPHs, and they do all have a different way that they want us to report in our positives or the vaccines or whatever it is. So a consistent platform with technology behind it would be fantastic, and a consistent approach from the payers. I think one of the themes has been, even if Congress mandates that payers must pay, even in the most recent FAQ that came out, that the payers interpret things slightly differently, and it's still a struggle for all of us to have to work with each payer in their interpretation of what they think it means. So clarity and consistency across the country, I think, would be exceptionally helpful from our perspective.
Thanks. Lisa, anything to add? I think that you're muted.
Yep, sorry, my computer froze. the tragedy of Zoom. I think a similar statement around consistency, and I would just add to that also around virtual visits. I think we all know that how much value there is to patients and to the health system overall to have this additional tool as an omni-channel, and there still is significant inconsistency in terms of parity for reimbursement or reimbursement for virtual visits as well.
Excellent point. Dr. Zipkin, any final answer?
Yeah, I mean, I hate to be a broken record here, but it comes down to standardization, 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 right? We have amazing colleagues in the departments of health across this country, but in leaving it to them to figure out how we can best report and record and register for all these processes, it really puts an unnecessary strain on them, some of whom are my friends, who I see, they struggle with trying to reinvent the wheel, 50 different ways across 50 different states or more. Here in New York, for example, there's a difference between the state Department of Health and the city Department of Health, each doing their own thing, each reinventing the wheel for themselves. When we standardize in medicine, we save lives. When we standardize in medicine, we can have early deployment, early responses. So my request to Congress is to please, to the best of our ability, creating one national standard, one national set of rules, set of changes, whatever they may be, would truly benefit us as a healthcare system across states.
Thank you. And thank you to all of you and your teams for everything that you have been doing and will continue to do. Now that you've had a chance to hear from our presenters, I hope it's been clear how important it is to include urgent care in all future pandemic and other disaster response plans. We were the first to diagnose a patient with COVID, and we've served a record volume of patients with testing and treatment, and now we're ready to provide those mass vaccinations and even serve as infusion centers for therapeutics where possible. We've heard over and over again that reimbursement for point of care testing is serious from a public health standpoint. And while the recent guidance did address some of those issues, there are a few remaining that are still going to be barriers and continue to be challenges for the rest of this season. We're happy to provide more information on that. And the final piece that you'll see noted on the slide here is that to continue the PPP funding to ensure that urgent care centers and small businesses are able to keep their doors open. This funding is essential for our industry. We want to thank everybody for attending this briefing today. Thank you to our panelists for participating. I hope that some of you have appointments scheduled with our members during our UCA Urgent Care Lobby Day tomorrow. For additional information, please contact Kim Youngblood, who is the Urgent Care Association Chief Governmental Affairs Office, at the email address you see on this slide. Thank you for your work in service of our districts and states and country, and again for joining us today. Thank you.